Hello everyone, welcome to Medicine with Faizan. Today we are going to learn how to localize a neurological lesion. Well, I can feel you. The neurophobia, we have all been there. But if you follow the correct scheme, apply the correct algorithm, then trust me, it becomes more of 2 plus 2 is equal to 4. Let's get started with scenario number 1, where a middle-aged patient presents with right-sided sudden onset weakness. Now, to localize a neurological lesion, you need to answer 3 questions. What is the lesion? Where is the lesion? And why is the lesion? I will apply step-by-step method and answer all these questions along the way. So the prerequisites are the same. You sanitize your hands, introduce yourself to the patient, ask for consent, place them in appropriate position, and expose them. In neurological examination, the exposure depends on what you are about to examine, right? And in this patient, since I'm going to examine the motor system, so I will expose him to the maximum. So let's get started. जी अस्सलाम वालेकुम, क्या नाम है? मेरा नाम डॉक्टर फैजान है, ठीक है। मैंने आपकी टांगों का हाथों का माना करना, ठीक है, इस जान की तकलीफ नहीं होगी। Now keep this in mind that when examining the motor system and you expose the patient, ask the patient to lift his trousers upwards himself. In that way, we will get an idea if there is any weakness in his upper limbs too. ये ट्राउजर ऊपर करेंगे अपने हाथों से, इस साइड से भी थोड़ी कोशिश करें, हाथ नहीं होती, चलें ठीक है. So you see, he is unable to use his right arm to lift his trouser. So we get an idea that there is a weakness in his right arm too. Not only is this in his legs. चलिए मैं खुद कर लेता हूँ, ठीक है. Now you inspect them carefully. Look for any abnormal posture like any decerebrate or decorticate posturing, any scar mark or any visible deformity in his limbs. So to examine the motor system, you need to follow these steps. You look for any fasciculations, grossly assess the bulk of the muscles, check the tone, power, reflexes, and clonus. And depending on your preference, you can either go with sensory examination first or coordination. It depends on your preference. And again, depending on what examination you are doing, like in this case, we are examining the motor system, so we will also assess the gait of the patient. So you tap the muscle to look for any fasciculations. The same you can do to upper muscles. And since right now we are only examining the lower limb, so I am not going to the upper limbs. Then you assess the bulk of the muscles grossly. You do not need to have measuring tape to exactly measure how many centimeters or inches. You can just grossly assess it. Just pick a point from where you are going to assess the bulk of the muscle. Like you can take the medial malleolus as your reference point, and from this to this distance, yes, it is bilateral comparable. Now tone. This is the way to assess the tone. So this side is normal. This side is, you see, hard to move, like it is spastic maybe. Then you assess the tone like this. So quite spastic. This one is okay. Now the power of the muscles. The correct way to check the power of the muscles is to ask the patient to lift their whatever limb you are examining. ये उठा के मेरे हाथ को लगाएं. So this is almost 3/5. Now you need to check how well they do under resistance. ठीक है, मैं दबाऊंगा, ठीक है, आपने मुझे नीचे नहीं करने देनी. So it is quite well 5/5. ये वाली उठाएं, टांग थोड़ी सी भी नहीं उठती, थोड़ा इस तरफ हिला के ऐसे 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 नीचे, ठीक है. So this side is weak, quite evident it is. अच्छा, नीचे को जोर लगाएं, नीचे को, शाबाश शाबाश, ठीक है. बाहर को खोलें टांगे. Again, the abductors are 3/5. Now we will examine how, we will assess how they perform in resistance. अच्छा, मेरे हाथ पे जोर लगाना है, मुझे अंदर नहीं करने देनी, बंद नहीं करने देनी. ये वाली भी ऐसी, ठीक है. अंदर को बंद करें. Again, the adductors are performing well, but we need to examine now how well they perform under resistance. मुझे खोलने नहीं देनी, ठीक है. अच्छा, ये इस तरह टांग इस तरह करें, उठा के, ठीक है, ठीक है. चलें बाहर को खोलें. You stable these muscles with your hand and check the power of only knee by asking him to straighten his leg. जी चलें, खोलें, शाबाश. Again, you stable the thighs by this and ask the patient to straighten his leg. जी मेरे हाथ पे जोर लगाएं, ठीक है. थोड़ा अंदर को खींचें, इसको अंदर अंदर अंदर, हाँ ऐसे, ठीक है. अपनी तरफ खींचें मुझे, शाबाश, ठीक है. रखते, ये भी ऐसे ऐसे ऐसे, अपनी तरफ खींचें मुझे, ठीक. नीचे को जैसे ब्रेक लगाते हैं, नीचे को करें. So it is 3/5. Now we will see how he performed against resistance. मुझे ऊपर नहीं करने देनी, शाबाश. ये करें, ठीक. ऊपर को करें, मुझे नीचे नहीं करने देनी, ठीक है. ये ऊपर हो जाएगा, ठीक है. चलो चलो, ठीक, ओके. Now we will check the reflexes with the clinical hammer. Always remember to explain the patient that you are going to tap this rubber thing at their tendons and it will not hurt them. अच्छा, ये रबर की है, ठीक है. ऐसे मारूंगा, लगती नहीं है ये, ठीक है. And you tap this rubber, this clinical hammer on the tendon and check the contraction of the muscle above it. You do not check the movement of the limb, you check the contraction of the muscle, right? So I will tap here and check the contraction here, not the movement of the limb, right? ढीला, बिल्कुल ढीला. And you let the hammer fall freely. So let's assume it is hyperreflexia in all his right lower limb. For ankle reflex, you place the legs in this position, lift the foot upwards, and then tap this muscle. This one like this, lift the foot and tap the tendon like this. Now the plantar reflex. For plantar reflex, you can use the key and again explain the patient that you are going to scratch the sharp end of the key against their foot, right? Sole of the foot, like this. अच्छा, ये मैं इस तरह लगाऊंगा, ठीक है, नीचे तलियों पे, आपको दर्द नहीं होगी, ठीक है. And also before attempting to check the plantar reflex, check the movement of the big toe, whether it is mobile or not, right? If it is injured for something or if it is immobile, then you won't get the reflex correctly. So you hold the leg firmly to prevent any abnormal response. First, yes, check the movement of the big toe, hold the leg, right this, and scratch the sole of the foot, right this. And where exactly you get the plantar response, uppoint plantar response, if you get it, you stop it right there. You don't move up because it will convert into then withdrawal response, and use the minimum scratch whenever possible. Because if you use higher intensity of the scratching, then it might also convert into withdrawal response. So let's suppose it is upgoing plantar here, right? Again, check here. So it is mute. This one, let's suppose, is upgoing. Now we are going to check the colonus. So to check the colonus, you bend the knee and do these movements at the foot. Right? Check the colonus in left leg too. So let's suppose colonus is present in right leg. So whatever examination we have done till now, we can see there is weakness in his right leg. And also in the start, we get an idea that there is also weakness in his right arm. So we call it hemiparesis or maybe hemiplegia depending on the severity of the weakness. So imprint this in mind. Whenever you are presented with upper motor neuron type weakness on one side like this, hemiparesis or hemiplegia, there are 4 conditions that can cause this. Stroke, whether ischemic or hemorrhagic, space occupying lesion, inflammatory conditions like MS, and towards paralysis. Now, we can do the sensory examination and coordination just to complete the neurological examination, but it is not going to do any significant help in identifying what is the lesion and then localizing where is the lesion. But if you are in exam setting, you can complete the examination by doing the sensory and coordination, especially if you are in MRCP UK exam, because they expect you to complete all the steps. For example, if the command was to examine the lower limbs, they expect you to check the sensory and coordination along with the motor system and maybe even gait too. But like I said, the goal here is to explain how to localize a neurological lesion. So as I said, the sensory and coordination is not going to do us any favor in that matter. But still, let's complete the examination. So I'm going to only check the pain prick sensations with this. You ask the patient if he can feel it on his forehead and then examine the limbs. अच्छा, ये लग रही है कि चुभ रही है?
लग रही।
ठीक है, आंखें बंद करें, मैं नीचे टांगों को लगाऊंगा, मुझे बताइएगा कि माथे जितनी महसूस हो रही है कि कम महसूस हो रही है. ठीक है, माथे जितनी
जी.
You don't touch the skin just once like this. No. You keep touching the skin and ask the patient if the feel here is equal to the feel on his forehead. हाँ जी, बराबर है माथे के?
जी.
बराबर?
बराबर है.
And one thing to keep in mind is that you check the sensations, especially pain prick or soft touch, according to the dermatomes. You don't just go in random fashion. You check them according to dermatomes. You can check out the dermatomal scheme of human body. Here I cannot go into the details of that. हाँ जी, बराबर है?
जी.
जी.
बराबर.
ठीक है, चले. So pain prick sensations are normal. Let's go with proprioception and vibration. अच्छा, ये देखें, ये ऊपर है, ये नीचे है. Ask them first the movement, explain them. Your command should be explanatory, not confusing. ये ऊपर, ये नीचे. आंखें बंद करें, मैं ऊपर नीचे करूंगा, मुझे बताइएगा. And the correct way to assess the proprioception is you hold the proximal phalanx like this and only do the movement at the distal phalanx. Because if you don't hold the proximal phalanx, he will be able to tell the movement by the pressure of your movement, right? Like if you hold it like this and move the whole toe, then he will be able to tell the movement. But if you press hold the proximal and move only the distal phalanx, then if proprioception is impaired, he won't be able to tell. ऊपर है कि नीचे? ऊपर है कि नीचे? ऊपर है कि नीचे? So proprioception again here is intact. Compare this leg to ऊपर है कि नीचे? ऊपर है कि नीचे? ऊपर है कि नीचे? Now let's check the vibrations. You strike the tuning fork to any surface to make it vibrate, and then you ask the patient if he can feel the vibrations. First check it on a normal area as a reference point, and then compare it on the limbs, right? And you need to place the tuning fork on any bony surface on the patient to and ask it whether he can feel the vibrations. थरथराहट महसूस हो रही है
जी
अब
बंद
ठीक है मैं नीचे टांगों को लगाऊं मुझे बताइएगा कि हो रही है कि नहीं हो रही है थरथराहट महसूस
जी
अब
हम्म,
ठीक हो रही है थरथराहट महसूस
जी मेरी तरह
अब
बंद हो गई
ठीक you can repeat the same process on his patella, and since we are doing only the lower limb right now, so I am not going to the upper limbs. So again, till now, as we discussed, we have got the answer to our first question: what is the lesion? So it is upper motor neuron type, right-sided weakness, right-sided hemiparesis. Now to the next question: where is the lesion? And to answer that, we need to examine the cranial nerves, because that's where the answer lies. Now you already know there are 12 cranial nerves. Cranial nerve 1 and 2 are in the cortex. The rest of the cranial nerves are in brainstem. You know, brainstem consists of midbrain, pons, and medulla. Cranial nerve 3 and 4 are in midbrain, 5, 6, 7, 8 in pons, and 9, 8, 11, 12 in medulla, right? So if there is any cranial nerve lesion on this side, the left side, and motor weakness on the right side, we call it crossed lesion, and the defect will be in the brainstem, right? So cranial nerve lesion on the side of the lesion, like here, left sided, and motor weakness on the opposite side of the lesion, on the right side. This is crossed lesion, right? And the lesion will be at the level of the brainstem. Now you already, as I have told you, from cranial nerve 3 to 12 are in the brainstem at midbrain, pons, medulla. So we do not really need to exactly pinpoint where in the brainstem. Brainstem lesion, that's enough to localize, right? So we do not really need to examine all the cranial nerves. We can just examine the facial nerve, and maybe if you want, if you have time, then maybe extraocular movements to look for any involvement of cranial nerve 3, 4, and 6, right? Because you see, in exam setting, you do not have enough time to do all the steps. You need to do focused examination to answer all the questions, right? But in practical life, you have all the time, so you can do all the cranial nerve examination. Right now, I'm just going to do the facial nerve examination. Maybe we can do the cranial nerve, the whole cranial nerve examination in another setting, right? ये उठ के बैठेंगे? So to examine the facial nerve, you know there are two patterns of weakness of facial nerve. One is upper motor neuron type weakness, and the other is lower motor neuron type facial nerve palsy, right? Like for example, if left-sided cortex is affected, you will be presented with weakness in the right lower half of the face, because the upper half of the right side of the face is still receiving supply from right side of the cortex, right? So it will be upper motor neuron type facial nerve palsy, but lesion will be on the left side, not right side. But if the lesion is at the level of the brainstem or below, in the peripheral course of the facial nerve, then both upper and lower half of the face will be affected, and you will see ipsilateral lesion. Like for example, if left-sided brainstem or below lesion is there, then you will see left-sided weakness of both upper and lower half, right? So coming back to our scenario, in cross lesion, there is lesion in the brainstem, right? So there will be ipsilateral left side of the facial weakness, both upper and lower half, and contralateral right-sided motor weakness, right? So to quickly examine the facial nerve, we ask the patient to frown, close eyes, and see whether he can close their eyes or not to look for any Bell's phenomena. Then we ask them to puff their face and smile to see any facial deviation, right? अच्छा, माथे पे तेवरी चढ़ाएं, बल चढ़ाएं, जैसे ऊपर देखते हैं, ठीक है, आंखें बंद करें, ठीक है, मुझे खोलने नहीं देनी, ठीक, अच्छा, मुंह में हवा भरें, मुझे हवा निकालने देनी, इस तरह करें. So let's suppose there is left-sided lower motor neuron type facial nerve palsy. Now what we will see, he will be unable to frown, unable to close his left eye, we call it Bell's phenomena. When he is asked to smile, this side of the face, left side of the face will be deviated, and there will be absence of the nasolabial fold, right? And from these features, we will get the idea that it is left-sided lower motor neuron type facial nerve palsy. Now again, right-sided hemiparesis, left-sided facial nerve palsy. So it is lesion at the level of the brainstem, and it is gross lesion. Now what if there is right-sided hemiparesis and right side of the face is affected? Right-sided upper motor neuron type facial nerve palsy. Now where is the lesion now? Now it will be uncrossed lesion, as both the cranial nerve lesion and the motor weakness is on the same side, so uncrossed lesion. And the lesion will be above the level of the brainstem. Now it can either be at the level of the internal capsule, it can be at the level of the corona radiata, or it can be at the level of the cortex, cortical lesion. Now how to differentiate between the three? So if it is at the level of the internal capsule, then you will see dense hemiplegia, meaning the severity of the weakness will be quite high, like 0/5 power in the upper limb, 0/5 power in the lower limb. So we will call it dense hemiplegia. And also there will be absence of cortical signs. What are cortical signs? Meaning his speech will be intact. Stereogenesis. What is stereogenesis? We ask the patient to hold an object and close his eyes, and he will be able to tell by the shape of the object what it is, right? 2-point discrimination, he will be able to tell the 2 points, right? Now what if the lesion is at the level of the corona radiata? So there will be differential weakness, meaning let's say if there is 0/5 power in the right arm, there will be 3/5 power in his right leg. So differential weakness. And again, absence of cortical signs, right? Now the third possibility, what if the lesion is at the level of cortex? So if the lesion is at the level of the cortex, then we will also see cortical signs, as I have already mentioned. There will be abnormal speech, abnormal stereogenesis, and all of the features. So this answers our second question, where is the lesion? How to localize the lesion, right? Now the third question, why is the lesion? Well, to answer that question, you need to have maybe the history, like if the patient has presented with sudden onset weakness, sudden onset hemiparesis, and he also has history of diabetes, hypertension, ischemic heart disease. So the probability of stroke is quite high. And we will also examine his precordium to look for any heart murmurs, right? We will examine his carotids, auscultate his carotids to look for any carotid bruit, carotid stenosis, and also assess his pulse if there is any evidence of atrial fibrillation, because you know atrial fibrillation can lead to thrombus formation and it can lodge into cerebral arteries, right? So these findings will answer our third question. So that sums up our first scenario, where a patient presented with right-sided hemiparesis, and we have answered the question, what is the lesion? It could be stroke as well, inflammatory conditions like MS and Tourette paralysis. We have answered where is the lesion, as if it is crossed hemiparesis, the lesion will be at the level of the brainstem. If it is uncrossed, there are three possibilities. It can be either at the level of internal capsule, corona radiata, and cerebral cortex, right? Now, moving on to our second scenario. So the second scenario, a 30-year-old patient presents with difficulty in walking, right? So by this command, we are supposed to examine the lower limbs. It is obvious. So again, the prerequisites are the same. We sanitize our hands, introduce ourselves, ask consent, place them in proper position, and expose them. And the patient is already exposed, so our requirements are almost fulfilled. So, अच्छा जी, मैंने आपकी टांगों को मुआयना करना है, ठीक है? इस आगे तकलीफ नहीं होगी. Again, check for fasciculations. Grossly assess the bulk of the muscles. Check the tone, power, reflexes, colonus, and then do sensory coordination. And also in this scenario, gait is also important, right? Although I'm not going to do that, maybe we can have another video for the gait examination. Here, I'm not going to do that, right? So I tap the muscles to look for any twitching. Grossly assess the bulk of the muscles. Check the tone. So it is stiff, tone is increased. अच्छा, उठा के मेरे हाथ को लगाएं, बस इतनी उठती है, ये भी उठा के लगाएं. So there is reduced power bilaterally. नीचे को जोर लगाएं, खोलें थोड़ा, बस जोर लगाएं मेरे हाथों पे. So the power is reduced here too. अंदर बंद करें टांगे, मुझे खोलने नहीं देनी. ठीक, शाबाश. इस तरह ढीला 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 छोड़ें, इस तरह रखें. You stable thigh muscles like this and ask the patient to straighten his leg. सीधा करें, मुझे जोड़ लगा देना. ठीक है, ये भी ऐसे ही सीधा करें, मुझे, हाँ ठीक है. अंदर को करें, होती है. ठीक है, अंदर को खींचें. ठीक, चले. नीचे को जिससे ब्रेक लगाते हैं, हाँ नीचे को मुझे ऊपर नहीं करने देनी. ठीक है, ये भी इस तरह नीचे को करें. ठीक, ऊपर नहीं करना. ठीक है, ऊपर करें, होती है. ठीक है, मुझे नीचे नहीं करने देने, ये भी मुझे नीचे नहीं करने देने. ठीक है, शाबाश. Now I will check the reflexes. Again, explain the patient that it is made of rubber, it won't hurt them. रबर की, ठीक है, ऐसे मारूंगा लगेगी नहीं. ठीक है. You tap the tendon again and look at the contraction of the muscle above, not the movement of the limb. Suppose there is hyperreflexia. For ankle, you bend the knee like this, uplift the foot, and tap the Achilles tendon. Again, let's suppose there is hyperreflexia. When checking the voluntary reflex, you explain the patient that it is a key. I will scratch the soles like this and it won't hurt them. And also check the movement of the big toe. You stable the leg like this and scratch the sole like this. So it is upgoing. Where you get the reflex, you stop the scratch right there. Otherwise, it will convert into withdrawal response. Again, the same here. So upgoing planters. Now we will check for colonus. You bend the knee and do these movements. So colonus is also present. So up till now, we can see that there is upper motor neuron type weakness in his both lower limbs. Now we need to check the sensory examination and coordination, because that's where the question lies. What is the lesion? Where is the lesion exactly? We have got the answer to our first question. What is the lesion? It is upper motor neuron type weakness in its both limbs, lower limbs. Now, where is the lesion? That question will be answered if we do the sensory examination properly. So if the sensations are intact, that will be something else. If the sensations are impaired, that will be something else. अच्छा, मुझे बताएं, ये लग रही है कि चुभ रही है?
लग रही।
ठीक है, आंखें बंद करें, मैं नीचे टांगों पे लगाऊंगा, मुझे बताना है आपने कि बराबर है माथे के कम है, ठीक है? Again, you don't just tap once, tap continuously and go in dermatomes, not random fashion. हाँ जी, लग रही है, चुभ रही है? माथे जितनी है जी जी जी, ठीक है जी जी। So pain prick sensations are intact. Now vibration and proprioception, I will just go with one because you have already seen how to do proprioception, just for the sake of convenience. थथराहट महसूस हो रही है जी? अब बंद। ठीक है, मैं नीचे लगाऊंगा, आंखें बंद करें, मुझे बताइएगा कि हो रही है कि नहीं। हो रही है थथराहट महसूस जी? अब बंद हो। ठीक, हो रही है महसूस जी? अब बंद होगी। ठीक, हो रही है थथराहट महसूस जी? अब बंद होगी। हो रही है थथराहट महसूस जी? अब बंद होगी। ठीक। So vibration senses are also intact, meaning his posterior column is intact too, right? Now the coordination. अच्छा, ये आपने ऐसे उठानी है, ऐसे करके उठा के फिर ऐसे रख देनी है टांग, ठीक है? करें, खुद करें, शाबाश, करें करें करें, उठा के रखते हैं इधर, ये भी ठीक, उठा के रखते हैं. So obviously this is a normal subject, so he can do coordination. If there is motor weakness, power is 2/5 maybe, then of course he won't be able to do the coordination because there is weakness. So I wanted to let you know about this because this is a normal subject. We are just mimicking the real life scenarios. So he is able to do the coordination. So upper motor neuron type weakness in bilateral lower limbs, meaning spastic paraparesis, but sensation and coordination are intact. I'm not going to do the gait, although in real life and even in exam you need to do that step too to get full marks maybe, and also to actually diagnose what it is. But let's say it is the gait is spastic. Let's suppose. So spastic paraparesis, spastic gait, sensations and coordination is intact. Now the differentials would be parasagittal meningioma, hereditary spastic paraparesis, MND, MS, and bilateral, rare, that is quite rare, bilateral strokes. So what are the conditions? Parasagittal meningioma, hereditary spastic paraparesis, MND, MS, and bilateral strokes. When there is spastic paraparesis but normal sensation and coordination, right? So that was our second scenario. Now moving on to third scenario. Again the same. Let's say 30-year-old male patient with inability on walking, right? So in this scenario, I'm not going to do all the steps, just hypothetical. You got spastic paraparesis, but now the sensations are impaired and you get a sensory level. I'm just going to do a sensory level, how to get the sensory level. जी, ये लग रही है कि चुभ रही है?
लग रही है।
ठीक है, आंखें बंद, मैं नीचे लगाऊंगा, मुझे बताइएगा कि माथे जितने कम है। नहीं पता लग रहा? जी
नहीं
जी
नहीं
जी
नहीं पता लग रहा।
नहीं पता लग रहा। दोनों साइड पे
दोनों साइड
नहीं पता लग रहा।
नहीं
हाँ जी,
नहीं
कहाँ पे महसूस होती है? यहाँ पे महसूस होना शुरू हो जाता है माथे जितना।
जी
So again, it is a hypothetical scenario, but in real life too, when there is sensory level and you are not getting any sensations in the lower limbs, and you are coming upwards, upward, upwards. Of course, you cannot examine the private parts, but when you ask the patient if where he can actually feel uh, equal to the forehead, then he will tell you. He will definitely tell you, doctor, above here, and then you will get the idea that the sensory level is around here. Maybe if they say above here, then the sensory level will be here, right? So just for the sake of dignity, I'm going to examine above. So you get the idea of, I'm sure you get the idea of how to get the sensory level. So coming back to the main scenario, then there is spastic paraparesis with sensory level, let's say around T10. Now also the vibration and proprioceptions are impaired. Now it is altogether a different scenario, and the differentials are different. The differentials could be either compressive lesion or non-compressive lesion, and the lesion is at the level of spinal cord. Compressive meaning anything might be compressing the spinal cord. It could be spinal abscess, spinal tumor, SOL maybe, or TB, spinal meningioma, all of that at the level of the spinal cord. Compressive lesion. Even myelopathy could be the cause. And you need to, that is emergency, and you need to rule that out in the emergency setting. Other differential would be non-compressive lesion, and the top of it is transverse myelitis, right? Now coming to our fourth scenario. Again, there is spastic paraparesis. I'm not going to do all the examination steps. And when you do the sensations, you only find impaired pain prick sensations, but proprioception and vibrations are intact. So you see, posterior column is intact, but spinothalamic tracts are impaired. So the lesion would be either syringomyelia or spinal cord infarction. These will be the two causes of such scenario. And finally, the last scenario in upper motor neuron type weakness, we will cover the lower motor neuron type weaknesses later. In this video, I'm only covering the upper motor neuron type weaknesses. So the last scenario in this video is again inability to walk or feel things, maybe spastic paraparesis. But in sensations, when you do the sensations, pain and temperature or pain prick are intact, but vibration and proprioception are impaired, right? And you also get Romberg, positive Romberg sign. How you do Romberg sign? You ask the patient to stand, his feet touching each other, and he's looking at the horizon and see if there is any imbalance in his posture. If there is any imbalance, then it could be related to cerebellum with eyes open. But if he closes his eyes and then there is imbalance, like he cannot stand still straight, then it is positive Romberg, and it is due to impaired vibration or proprioception, impaired proprioception actually, and the lesion is at the level of the posterior column, right? So spastic paraparesis, intact pain prick or temperature, and impaired vibration and posterior proprioception. So now the causes will be, you can remember the mnemonic CMAST: cervical myelopathy, MS, Friedreich ataxia, and subacute combined degeneration syndrome, like due to vitamin B12 deficiency, and Tabes dorsalis due to syphilis. That is quite rare now. So this is how you localize a neurological lesion on the basis of the findings, and I hope you get the idea of it, and with practice you will get used to it. You will get used to the scheme and how to apply the algorithm. Maybe you can watch the video again and again to get the idea. For further videos about lower motor neuron type weakness, stay tuned.